Good afternoon. Good afternoon, Dr. Hirokan.
Good afternoon, Dr. Hiroka.
Yes. Can you hear me?
Yes, loud and clear. Clear.
Now it's 6:30. Can we start now? Can you hear me, Dr. Hiroka?
Yeah.
Okay.
Good afternoon, Mr. Hiroka.
Yes.
Can you hear my voice?
Yeah, but I can hear some noise.
Okay. I will try to fix it.
Okay, good.
Okay, good. Thank you.
Okay, it's better.
Shall we start, Dr. Andy Tenry?
Yes. So we start now, and now please the MC to start the meeting today.
So, Assalamualaikum warahmatullahi wabarakatuh. Greetings and best wishes to all of us. Good evening, ladies and gentlemen. Welcome to the case discussion by Makassar Eye Hospital with Hiroshima University, and thank you for joining us through this online meeting. May I introduce myself first? My name is Nurul Iza Sanusi, MD, and I will be your host for this evening's discussion. But before we begin, please keep your microphone on mute during the presentation, and you may type your question in the chat box or use the raise hand feature if you wish to speak directly. First, warm welcome to Kazuyuki Hiroka, PhD, MD, Mr. Naoki Okada, PhD, MD, and all colleagues from Hiroshima University, as well as our distinguished doctors and participants from Makassar Eye Hospital or from other institutions. Let's start our event with welcome remarks from our distinguished guests first. We are honored to begin with Prof. Udu, PhD, MD, as the President of Indonesian Ophthalmologists Association. So good evening, Professor. It is such a pleasure to have you with us today. Please, the screen is yours.
Thank you very much. Good evening, everybody.
Good evening, Professor.
Yeah, the director of Eye Hospital Makassar, Dr. Asnada, the Indonesian Ophthalmology Association of South Sulawesi, Dr. Tendisana, and the special our speaker from Hiroshima University, Dr. Hiroka. Thank you very much for your coming to this online meeting. Can you help me, sir? Very excellent meeting together with Hiroshima University and Makassar Hospital with the title of glaucoma cases discussion, the first cases, malignant glaucoma and challenging management. And we hope this meeting will improve our knowledge about the glaucoma, specifically for malignant glaucoma. we know that malignant glaucoma is very challenging cases, and for this meeting, we hope we can change our knowledge between Hiroshima University and Makassar Hospital in Indonesia. So once again, thank you very much, and we looking forward to hear sooner the material from the Hiroka and all of the speaker today. Thank you so much.
You're welcome.
Thank you so much, Professor Budu. Next, we would like to continue to welcome remarks with Kazuyuki Hiroka, PhD, MD from Hiroshima University. Good evening, Dr. Hiroka. We are honored to have you with us again today. Please, the screen is yours.
Good evening, everyone. I'm Dr. Hiroka from Hiroshima University. It is my pleasure to have a glaucoma case discussion tonight. It would be an honor to continue deepening a mutual exchange and knowledge through glaucoma case discussion. Anyway, thank you so much. Thank you.
Thank you very much, Dr. Hiroka. Next, we would like to continue towards our next agenda. We would like to invite Dr. Asnada, Master of Health Administrator, as Makassar Eye Hospital Director. Please, the time
Thank
is
you.
yours.
Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone. Warm greeting for all of us. And konbawa. Distinguished guest, Professor Budu, MD, PhD, President of Indonesian Ophthalmology Association, Kazuyuki Hiroka, MD, PhD, Head of Glaucoma Department at Hiroshima University, Naoki Okada, MD, PhD, Ophthalmologist at Hiroshima University, esteemed ophthalmologists, nurses, and healthcare professionals from Makassar Eye Hospital, all respected participants of today's case discussion. First and foremost, let us express our gratitude to Allah Almighty for His grace and blessing as we are gathering here for the case discussion between Hiroshima University and Makassar Eye Hospital. This activity represents an important step in strengthening our international collaboration network, particularly in field of ophthalmic services, education, and research endeavor in relevant fields. Through scientific forums such as this, we can share experience, broaden our perspective, and deepen our understanding through knowledge exchange of the complex case in ophthalmology. We believe that this collaboration with Hiroshima University will not only enhance the scientific capacity of our medical professionals at Makassar Eye Hospital, but also foster innovation and new approaches in patient care in line with the latest development in medical science and technology. We sincerely hope that today's program will run smoothly and bring meaningful benefit to both institutions, serving as a foundation for closer collaboration in the future. For example, in transnational research, specialized medical education, and training exchange program. We would like to express our sincere appreciation to our distinguished colleague from Hiroshima University for their willingness to share their expertise, as well as the all committee members and participants who have participated and contribute to the success of today's case event. This scientific discussion bring valuable insight and contribute to improving the quality of eye care services in Indonesia and also in Japan, respectively. Thank you. Yoroshiku onegaishimasu. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Asnada, for your warm greetings. Before proceeding, allow me to introduce our moderator for today. So our moderator is Dr. Andi Tendrisana Devi. She is an ophthalmologist at Makassar Eye Hospital. She completed her ophthalmology degree at Hasanuddin University. She also completed her glaucoma fellowship in Sishendo Hospital and ICO Arifin Eye Hospital in India. She's a lecturer in glaucoma subdivision in Hasanuddin University. She is now working as an ophthalmologist and director of medical service in Makassar Eye Hospital. The session will then proceed with the question and answer, a conclusion which will be guided by our moderator. So without further ado, I now hand the session over to our moderator, Dr. Andi Tendrisana Devi. Please, the time is yours.
Thank you to the MC. Now we move to the next session. In this session, we will have one lecture and two case presentation. So Dr. Aryani will speak about malignant glaucoma. So let me introduce Dr. Aryani. Dr. Aryani is an ophthalmologist and her background education from Hasanuddin University in Indonesia. And then she have a fellowship in glaucoma fellowship in Hiroshima University and also observership in National University Health System in Singapore. And her professional experience now, she worked in Rumah Sakit Mata Makassar, Indonesia. So Dr. Aryani, now the time is yours, and then you have about 10 minutes to give the lecture.
Okay, thank you, Doc. Good evening, everyone. I would like to share my screen. Is everyone seeing my screen? Okay. Thank you and good evening. My name is Dr. Aryani, and I would like to give short lecture or a little bit my knowledge about malignant glaucoma, which is we know that a surgical challenge for every ophthalmologist. Back to historical perspective, that we know that in 1869, von Graeff said that he found the first time glaucoma malignant right after his surgery, and then he found anterior chamber shallowing despite patent iridectomy. That's why he called term malignant glaucoma, because it's aggressive nature and poor prognosis, also poor response to conventional treatment. But in 1982, Schaeffer and Hoskins said that the term malignant glaucoma is not correct, because they say that measure of cases is the underlying mechanism is from ciliolenticular block theory. That's why they say that the ciliary block glaucoma is more corrected. So now at present, advancing imaging and surgical techniques would also give us a good management to do outcome surgery. So malignant glaucoma, also known as a ciliary block or aqueous misdirections. We know that it's a rare condition, typically manifest following intraocular surgery, especially in eyes with anatomical predispositions. The incidence following filtration surgery is high, is about 2 until 4%, especially in the filtrating surgery as like trabeculectomy. And 20% in eyes with multiple risk factors such as non-ophthalmic eye or pre-existing angle closure glaucoma right before surgery. And we could see here in the graphic that the angle closure glaucoma is divided into two, primary and secondary, which is the secondary is without pupillary block, which is we know that we might want to distinguish between pupillary block and without pupillary block. And malignant glaucoma has a mechanism that can cause a pulling from the posteriorly to the anteriorly. Also reported that peripheral iridectomy or iridectomy right after cataract extraction has also make a high risk of these conditions. Combined cataract glaucoma surgery, posterior segment surgery, and even in 2023, Mehta needs say that malignant glaucoma also present after gonioscopic assisted transluminal trabeculectomy. So for pathophysiology, although that we know that pure mechanism of glaucoma, malignant glaucoma is not so understandable, but Schaeffer and Hoskin said that the posterior pulling of aqueous is the main cause of this condition. Because we see this in these pictures, there is aqueous inside or within or beside the vitreous that can make the pushing mechanism to the anteriorly. Why does exactly the aqueous humor go posteriorly instead of going to the anterior? You can see here the ciliolenticular block. Ciliolenticular block is the main mechanism, because they say that sometimes ciliary block is go rotationally to the anterior position. That's why in this second picture, we could see here that the ciliary body was touching the lens equator in this arrow. So we can see instead of going to the posterior chamber, the aqueous humor goes to the vitreous chamber. That's why the pulling condition is happening. At the second, anterior hyaloid obstruction is also being connected to it, because they say that every break or every tear in hyaloid near the vitreal space, we could see in the third picture here, this will allow aqueous to moving to posteriorly or diverted to posteriorly, that can cause intravitreal pressure is high. So the next theory that say that slackness of lens zonule by Chandler and Rand, that they say that every kind of zonulopathy would also make this condition, or the anteriorly moving of this iris diaphragma is easier to happen. And the last one is the choroidal expansion. We could see here that sometimes when there is a posterior detachment of vitreous, there is a diffusion of fluid through the vitreous, which is will go to the anterior chamber and then exit or through the trabecular meshwork or ovuoscleral pathway. Well, we can see here at the second picture that the choroidal expansion is happening, and it's the IOP is high, and then right after the aqueous humor is exit from the anterior chamber, there will be a different pressure between the vitreous and the anterior chamber. That's why that every mechanism of it, and then every cycle of it, that makes the impermeable of anterior hyaloid, that pushing everything to the anterior condition. That's why we will get this number 3. The diameter of lens and iris will go directly to anterior and make the flat of the anterior chamber. As a risk factor, we could see all of the non-ophthalmics or short axial length, less anterior chamber depth, or thick lens combined with the short axial length could be really predisposing eye. Use of myotics, prolonged of use of myotics also can be connected to this condition. Post-surgical or laser, we could see in this picture a very short eye, or maybe this condition like female with exfoliation syndrome, and historical of fellow eye has a malignant glaucoma. So how exactly we are going to diagnose this condition? Typically, patient will come with us with red painful eye, high IOP, shallow to flat anterior chamber, and the best is they have a very shallow anterior chamber in axial or centrally. So it will make us to think about malignant glaucoma, despite of another optional or another angle closure glaucoma. There is a pattern iridectomy also can make our diagnose, and decreased vision actually due to the corneal edema, refractive changes. Also, we can find myopic shift in patient. Despite everything in before, we could see normal posterior segment anatomy. So examination, we might want to check IOP gradually, because sometimes the malignant glaucoma doesn't have any IOP high unless the angle is close enough. And the slit lamp, we could find corneal changes, how iris form, is there any pattern PI or anterior chamber depth, and especially in lens position to the centrally. So for gonioscopy, do it routinely also and feasible in most cases. But we could see maybe there will be a close gonioscopic finding, or we could see the ciliary body so easy because there is a lens go far forward to the anteriorly. For gonioscopic, we can check or we can compare to the fellow eye to see if there is a difference between two eyes. So we could do another investigation if we want to convince ourselves with the malignant glaucoma situation. We can do B scan, use ultrasonograph or UBM or ASOCT to confirm it, because we in ASOCT and UBM we could see ciliary body rotation, and we could see how the IOL in pseudophakic eye move to or shift to forward, and we could see the posterior chamber and anterior chamber flattening. So the key to recognize is axial anterior chamber, because whole lens of iris diaphragma is shifted forward in this condition. To differential diagnosis, I divided into two, because the first one is anterior chamber, because in the anterior chamber we will have pupillary block and acute angle closure glaucoma. In here we could see iris bombay, which is iris bombay also found in pupillary block glaucoma, but even if there is a close, very tight or closed anterior chamber in periphery, but the centrally it actually has more form in angle closure glaucoma or acute pupillary block glaucoma. But in malignant glaucoma, there will be flat from the anterior peripherally to the central. In the posterior chamber, we could differential diagnose with choroidal effusion and suprachoroidal hemorrhage, which is these two conditions. We will have B-scan ultrasonography to see if there is any change of anatomically posterior change, and it will be distinguished as to malignant glaucoma. So how about if we diagnose malignant glaucoma? We might want to, as soon as possible, to do mydriatic cycloplegic to make the aqueous, to make the zonule go back and the posterior movement to the lens and iris. And we could do aqueous suppressant or alpha agonists and carbonic anhydrase inhibitor or osmotic agents if there is a very high IOP, and steroid to control the inflammation. But not in medical therapy that there is no using of myotics, are absolutely contraindicated. And if you use myotic, just stop the myotics and change to the cycloplegic. So the phakic, right after medical therapy, and if it's not work, we can wait, and it's not work or getting worse, we have another choice. The first one is pseudophakic or phakic patient and a phakic patient. It's more easier to have a pseudophakic or a phakic patient, because when it's a phakic patient, we have to do cataract extraction or an IOL implantation, and maybe we could combine it with vitrectomy. But in a pseudophakic or phakic patients, laser therapy also a good play a role in here, NDX laser, such as NDX laser capsulotomy or yak hyaloidotomy. And after that, maybe there is a transscleral cyclodial laser and surgical therapy as a vitrectomy surgery. So we can combine anterior vitrectomy, PPV, or maybe vitrectomy with iridozonulo hyaloidotomy. And the last one is posterior sclerectomy and air injection. So laser treatment here, actually just like NDX laser and or hyaloidotomy, is we make disrupting the anterior hyaloid phase or the posterior lens capsule and hyaloid phase, because this approach lead to relieving this entrapment of aqueous that been in vitreous to come out and have a connection again with anterior chamber. That's why the transscleral cyclodiode laser photocoagulation also can be done. As an alternative, we could do direct argon laser to ciliary processes from a peripheral iridectomy. So we have a next surgical intervention. There is a iridozonulo hyaloidotomy, which is I learn about the journal. All of journals say that it's a very good option for glaucoma malignant because we make a direct communication to the anterior chamber to the vitreous and make sure that we do tear and rupture to the hyaloid, anterior hyaloid. For pars plana vitrectomy, this picture I took from Professor Iksan journal in 2021 that they do posterior vitrectomy to the very angle closure suspected or malignant suspected. So the last one is posterior sclerectomy. We might want to check that posterior sclerectomy is, we do sclerectomy, two small sclerectomy and then after that we make a scleral flap from outside and we just let the sclerectomy open and close the scleral flap and conjunctival suture and just to allow the drainage even after surgery. Okay, thank you so much for me. So,
Thank you very much, Dr. Aryani. It's very on time, and then it's very nice presentation from Dr. Aryani. So now we move to the second speaker. The second speaker will present about case and let me introduce you Dr. Mirella. So Dr. Mirella finished her study in a Faculty of Medicine in Hasanuddin University and also ophthalmologist department in Department of Ophthalmology in Hasanuddin University. She have a fellowship in Rumah Sakit Mata Cicendo, Bandung in West Java, and she done the fellowship of investigation in India. Now, Dr. Mirella working in the Jakarta as hospital and in clinic and also in the hospital. So, Dr. Mirella, time is yours.
Thank you, Dr. Risana. Good evening, Prof. and doctors. First, I like to thanks this opportunity from Rumah Sakit Mata Makassar and Dr. Asnada for give me opportunity to present this case presentation. Okay. Okay. Share screen-nya. Yeah. Okay. Sorry for this technical. I cannot share the screen. I cannot share. Okay, thank you. So this is the case about a patient with flat anterior chamber after glaucoma filtration surgery. I have no conflict interest in this presentation. So this is a woman, 16 years old, with history of post-trabeculectomy about 2 months ago and phacoemulsification with IOL 3 weeks ago in the right eye. She already underwent cataract surgery in the left eye from other clinic in 2019. She has a systemic disease, hypertension, and history of using glaucoma medication since 2019, and also have a family history of glaucoma, her siblings. So actually, the first she came to our clinic I don't have the record of the photo of history, so we performed the trabeculectomy and we performed the phacoemulsification with IOL. But after the phaco, we can see from this slide the visual acuity on the right eye is 2400 and the IOP is 39. Conjunctiva was hyperemia and the anterior chamber was flat, grade 2. The pupil was about mid-dilate and there is already IOL in the posterior chamber. On the gonioscopy, all quadrant was, we can see it's all peripheral anterior synechia. While in the left eye, she already have no light perception and the IOP was 57, but the anterior chamber was formed with Van Herrick grade 2. Also, the gonioscopy, all quadrant with synechia anterior, peripheral anterior synechia. So this is the OCT. We can see the OCT, the RNFL, and the anterior chamber OCT. We can see the flat AC with part of the iris was touching in the endothel of the cornea, and the ultrasound of the right eye. We can conclusions there is no choroidal detach or suprachoroidal hemorrhage. So we diagnose this patient with chronic primary angle-closed glaucoma, already post-trabeculectomy, and suspect of malignant glaucoma. And the left eye with absolute glaucoma and both eye with pseudophaky. So we treat with antibiotic, topical antibiotic, timolol maleate on the right eye and latanoprost in the both eye, atropine sulfate in the right eye, and orally acetazolamide and kalium. So this is the biometry of the patient. We can see she has a axial length is quite normal. In the right eye is 22.03 and the AC is quite shallow. It's about 2.3. Okay, and I give you the brief history because this patient already underwent through some of the procedure, laser and surgery. So she came to us in the February 2021, and because of the high IOP, we performed trabeculectomy with 5 fluorouracil, but it doesn't. The result was still high in IOP, so I decide to do the phacoemulsification because this is the PSCG patient, so we need to remove the lens. But after that, still there is a hike in IOP and the anterior chamber was still shallow. And we performed the YAG laser, and after that, also laser peripheral iridotomy again, because in the trabeculectomy, we cannot observe the iridectomy while we perform the trabeculectomy before. And we perform also bleb needling because the bleb is still flat, but it doesn't improve. So we perform GDD implant with vitrectomy pars plana, and at the end we perform again iridosonula hyalodovitrectomy. So I give the history of laser. After we perform the YAG laser, the IOP is 15. It's quite good, but still on topical and oral anti-glaucoma medication. But after several weeks, the IOP is raised again, and because there is no patent iridotomy, we decide to do another peripheral iridotomy. But at the end of the month, the IOP was raised to 55. So we decide to do the glaucoma dry night device implant because I think the flap was very flat. There's no bleb form, so I decided to do the glaucoma dryness implant with vitrectomy pars plana. We can see after the surgery on day 1, the IOP was still in 26. And the OCT of the anterior chamber was still flat after the pars plana vitrectomy. So we follow up a few months. IOP was up and down, but never on the target as we decide. And the anterior chamber was still flat in grade 2. We can see only in the pupillary border, there is a little space between the endothel and the IOL. So at the end, we perform iridozonular hyaloid vitrectomy. So this time we want to make a unicameral between the anterior chamber and the posterior chamber. So I work with the retina specialist to this procedure. And after the surgery, on the day 1 post-op, the IOP was down to 15. And the visual acuity was improved to 20/80. After 1 month, the IOP was still under 20, it's 18. And we only use topical anti-glaucoma medication without oral anti-glaucoma medication, just topical, 2 topical glaucoma medication. This is the history of the IOP. We can see before the iridozonular hyaloid vitrectomy, the IOP was up and down. But after the procedure, it's quite stable with 2 topical glaucoma medication. So this is the patient after 3 years. We can see the OCT was well formed, and we can see the tube in the anterior chamber also quite in the good position. For the left eye, because it's already no light perception, we decide to do the transchiral cyclophotocoagulation to manage the intraocular pressure. So we follow up this patient until now. It's already about 3 years from June to 2025, about almost about 4 years. So we can see we evaluate the corneal endothel from 2021 and 2025 is a bit reduced from the beginning because she had already underwent multiple surgery. But the visual perimetry, it's quite stable. At the end, it's still in about 31% with deviation about minus 23. So we know that the risk factor from flat anterior chamber already already present by Dr. Aryani. So this is all the type that our patient is about 60 years old. So she has the risk factor for flat AC. Okay. And she already used for a long time the oral glaucoma medication also. About the diagnosis for malignant glaucoma, actually we don't have the ultrasound biomicroscopy, so we just depend on the OCT anterior chamber, ultrasonography to make the diagnosis for this patient. And our treatment strategy for this patient is just to managing the IOP and make a unicameral eyes, and just to make the anterior segment to the normal anatomy. So this is the management of the malignant glaucoma according to the European Glaucoma Society. Okay. So from this case, I want to conclude that just to remind all of us that early diagnosis and prompt treatment are necessary, especially for this patient with the last eye, and always make sure to inform constant the patient about the possibility of more than one surgical procedure, because actually this patient refused to do the multiple surgery. That's why it took about 1 year before she underwent to the iridosonular hyaluronidectomy. And we collaborate with other ophthalmology division to treat special case. Like I think this case is need collaboration with retina specialists. Okay, these are all my reference, and thank you for the opportunity. I hope you give me advice or comment. Thank you.
Thank you, Dr. Ella, for the very interesting case. To describe your case and management so clearly. So now we move to the last presenter. The last presenter will be Dr. Naomi Okada. I'm so sorry, Dr. Okada, if I mention your name wrongly. So let me introduce Dr. Okada. So from his profile, we can see that medical studies from Faculty of Medicine in Hiroshima University, and for ophthalmologists from the Department of Ophthalmology, also in Hiroshima University. So we can see from the CV that she have so many works and journals, and it's a very interesting title that we can see from what he have done. So to Dr. Naoki Okada, MD, so time is yours.
Thank you, Dr. Andy. Can you hear me?
Dr. Okada, you can begin. Can you hear me?
Yeah, I can hear you. Okay.
Okay, I can hear you now.
Can you see my slides on the monitor? So let me start my presentation. I will talk about the case of bilaterally malignant glaucoma and deal with the technique of IZHV, the iridozonular hyaluronide vitrectomy. I have no conflict of interest. Let me introduce the malignant glaucoma. It was described by von Graefe in 1896 as form of glaucoma that was resistant to any of the treatment at that time. A forward movement of the lens iris diaphragm due to an overhydration of the vitreous is thought to be one major causative mechanism of disease. IZHV is one of the treatment choice for resolving malignant glaucoma. I will introduce my patient profile. She is 78 years old female. She has been diagnosed as primary angle-closure glaucoma bilaterally 2 years ago at local doctor. She was referred from local clinic to Hiroshima University Hospital for glaucoma surgery. Let the day of the surgery be day X. Before 3 weeks before, she visited us, and as for visual acuity, 20 centimeter hand motion on right eye and 615 on left eye. IOP with gold myelination tonometer, it was 25 millimeter mercury in right eye and 24 millimeter mercury in left eye. She has been prescribed retinoprost, calcium bilaterally and brimonidine, brinzolamide combination drug bilaterally as well. Her treatment history is as below. On day X, I performed trabeculectomy phaco, and she has a donor weakness, so I implant the CTR as well in left eye. And after 3 weeks from left eye surgery, I performed the traphaco on right eye. And unfortunately, after 1 week, she has shown the very shallow anterior chamber, and I diagnosed as malignant glaucoma on right eye. So I deal with IZHV technique. Her systemic past history was hypertension and well-controlled type 2 diabetes. This is the situation of after 8 weeks after left eye surgery. Visual acuity became 6.6 in left eye, so she's satisfied with the result of surgery. And pressure is 10 millimeter mercury and 9 millimeter mercury on right eye. She no longer needs any more glaucoma medications, and cornea was clear, AC deep. The PCIR was fixed well, and the fundus shows no signs of choroidal effusion. And disc was pale, and CDR was 1.0 bilaterally. At this time, brave was well formed, but cornea endocellular cell density was very severe. Both sides has under 1,000. And this is a visual field test for left eye. And the left one is a Goldman periphery, and the right one is a Humphrey 10-2 program. She has very severe central visual field defect. This is a transient of intraocular pressure in left eye. This is when I performed the traphaco on day X, and after 11 weeks from the first operation, she was diagnosed as malignant glaucoma. This is the detail. She complained about blurred vision in left eye, and the visual acuity was 615 with correction left eye, and the pressure becomes 31 millimeter mercury. And the cornea shows very edema, and AC is getting very shallow, but the center of the AC is not so flat. So I diagnosed as this malignant glaucoma, and I tried 1% atropine sulfate, but this trial was failed. And I tried YAG capsulotomy as well, but this trial was also failed. So as left eye is last eye, and it has vulnerable cornea and cerebral cell. So I considered the IZHV to her. This is a cashier. IOL moved forward, and peripheral AC is flat. And the breath was formed very slightly. This is a movie of the IZHV. I apologize for the poor image quality. I insert a knife towards the center of the eyeball. This one. You can see the iridectomy site. Advance runs through the iridectomy to puncture the anterior vitreous cavity. As the anterior chamber has not yet formed at this stage, I insert the vitreous cutter directly and perform both doneurectomy and vitrectomy for a while without irrigation. At this time, we can't see anterior chamber, but After while I will notice the anterior chamber forming, and while irrigating the anterior chamber with my left hand, I add the vitrectomy. You can see the donesis of the IOL. So I don't make any port of the vitreous vitrectomy. I only use the cornea port. So I will talk the post-op cost. After IZTV, IOP remains around 10 mm mercury without IOP-lowering medications. And visual acuity recovered to 6.6 without corrections. So she is satisfied, very, very satisfied. And she used 1.5% levofloxacin and 0.1% betamethasone TDS for 1 month post-op. This is a transient of pressure, including post-op course. At this time, I performed the IZHV, and after surgery, the pressure remains around 10 mm mercury. Treatment strategy for malignant glaucoma is medical therapy. As for medical therapy, we can use the myodiuretics and aqueous suppressants like beta blocker. And for laser therapy, we can use YAG laser to perform a posterior capsulotomy and anterior hyalodotomy. As for surgical therapy, if the patient is phakic, we can perform a phacoemulsifications. And if patient are phakic, pseudophakic, we can perform IZHV. As Dr. Riani already told us the mechanism of malignant glaucoma and IZHV, I add some information. This is from the article figure. Vitreous cutter introduced through iridectomy to perform a zonurectomy. And this cutter rotated anteriorly to white arrow and performing anterior hyaloidectomy. Anterior hyaloid face completely debarked with performance of a primary posterior capsulotomy with anterior vitrectomy. So IZHV can resolve the malignant glaucoma. Even for glaucoma specialists, IZHV is not a difficult technique because we don't need to make a vitrectomy port on sclera. Thank you. This is all.
Thank you very much, Dr. Hiroka. It's a very interesting cases, and then you explain us very systematically. So if you don't mind, while we are waiting from the chat box or anybody want to ask, if I don't mistake, the first for the management of your patient, the first time you put atropine, and then I don't know how long you put the atropine, and then you think that you have to do the laser with ND-YAG. So I've tried do YAG laser also, but it's quite tough because I done it blindly. So how do you do the YAG laser? And then how long do you wait? So you will decide that I want to perform the surgery for this patient. Thank you.
Yeah, the first step is atropine and Diamox to to prevent the but if the intraocular IOP is amazingly high, I recommend immediately the surgical procedure. So as it HB, I recommend.
So, I mean, you don't have to wait until how long, and then we decided that we have to do the surgery for this patient. So we just see the cleanness of the patient, like the IOP, like that, doctor. I mean, how long we do like atropine, give atropine, or maybe the NDA laser. So we decided to do the surgery for the patient
How long?
like this.
So
Or we
how you asked question how long?
sorry, maybe you mute the. I cannot hear you.
Yeah.
Yeah, I can hear you now. Can you hear me now? Sorry, Dr. Hiroka.
Yeah,
Can you hear me?
I can hear you.
Okay. Sorry, I cannot hear you before. Can you repeat it again, please?
Also, sorry. Can you tell me again?
Yes, I'm so sorry we cannot hear you before.
Now I can hear you.
Can you repeat your answer, because I don't hear you before.
Okay.
Yes.
So the first
Sorry.
step, I use atropine and Diamox to reduce aqueous humor production. But IOP is extremely high. I recommend the immediate surgery. I recommend the surgical procedure. Maybe 30 to 40 millimeter mercury, more than 30 to 40 millimeter mercury. I recommend the immediate surgical procedure, IZHV.
Okay, thank you, Dr. Hiroka, for answering the questions. Now, and then have you tried to do hyalurotomy?
Sorry?
Have you tried to do hyalurotomy?
No.
No, yeah. If I try, I cannot make it also because it's blind.
Yeah.
Yeah. Okay, thank you very much. And then the second question we have from the chat box from Dr. Hiroka to Dr. Mirella. I have a question to Mirella. Was the patient you present in your presentation was PACG? If so, why was this patient performed trabeculectomy alone, not with cataract surgery? So why not combine surgery? Why just do the trabeculectomy? Maybe like this. Okay, please, Dr. Mira, maybe you have some reason for that.
Okay, thank you for the question, Prof. Hiroka. So at the presentation, the patient was the IOP was about 40 to 50, as I remember. So I decided to do just trabeculectomy because I think the IOP is too high and the left eye is already no light perception. So I think for safety reason for this patient, I decided to do trabeculectomy first. After the IOP is well controlled, then I do for the phacoemulsification. That's my reason for this patient.
Oh yeah, and then I want to ask Dr. Hiro, Dr. Mira have answered that because the IOP is high, so she didn't want the combined surgery. So she done step by step, and the first is trabeculectomy. So maybe you can explain to us your experience in managing patient, especially in a glaucoma patient. So do you have a prefer IOP that which in what IOP you do it by trabeculectomy and then you do combined surgery. So what? Yes.
If the patient is a PACG,
Yeah.
every time I use a combined surgery, not only trabeculectomy, with a cataract surgery, because if we can only the trabeculectomy, maybe the malignant glaucoma is occurred. It's maybe it's a risk factor to be in a malignant glaucoma. So I recommend that combined surgeries. I recommend.
So, in your experience, so do you have a limit for the intraocular pressure? I mean, if patient come with because some of our patient in Indonesia come to the clinic when they, not all of the patient come with 25, but some patient also come with 50 millimeter mercury with PACG. So do you think we can do it, although in 50 millimeter mercury, we do combined surgery? And then if we do in condition like that, so do you have maybe any suggestion? So how we reduce the IOP, maybe with mannitol or maybe not just mannitol? Maybe do you have another experience?
No. Maybe, maybe I have no experience. Sorry.
If the patient have a very high IOP, for example, the patient come to us with 50
50.
millimeter mercury. So do you prefer to do that directly combined surgery, although the IOP it's about 50?
It depends on the IOP. It depends the type of glaucoma. So anyway, in the PACG patients, combined surgery is necessary.
Okay, so you don't have a preference that in PCG, although the patient 50, you also done the combined surgery.
Yeah.
Okay. So there is also a question in the chat box. One of the from ophthalmologist. It's about 2 days ago. I performed cataract surgery and suddenly the ICD is very shallow. And because the lens is mature, the PCR happened during chop. Is that a malignant glaucoma or what? Can you tell us what should we do if things this happen before the surgery? The IOP was 11 millimeter mercury. Maybe you have an opinion, Dr. Hiroka? Can you see the question from the chat box?
So after the cataract surgery, the anterior chamber depth was very shallow. Is right? What's the lens?
Yes.
Oh, the PCR happened during the chop. Okay. Maybe the IOL fixation is this side, no? I don't know.
I think she
This
done
question?
the cataract surgery
Yeah.
and then the PCR, posterior capsule rupture during
Yeah.
phaco.
Posterior
So
capsule
she
rupture.
asked,
I
is
see.
that a malignant glaucoma? I think
I see.
it's not. Yes.
The information is anterior chamber depth is very shallow, was very shallow,
Yes.
and the posterior capsule rupture happened
Yes,
during
posterior
the
capsule.
cataract surgery. I don't know. During the cataract surgery, anterior vitrectomy was performed, right?
No, I
Anterior
think
vitrectomy was performed.
no.
No.
She only done cataract surgery.
Yeah,
And
I know
then-
that, but posterior capsule rupture was happened. So
Yes.
the herniation of vitreous was occurred at that time. No?
Excuse me, Dr. Hiroka. This patient, this patient actually, by accident, when she do phaco emulsification, the PCR happened, and all of the sudden, the very shallow anterior chamber depth is happening. So I'm not sure, because malignant glaucoma also can cause intraoperatively, right? Malignant glaucoma could happen intraoperatively, but we're not sure because there is no history of angle closure glaucoma before that can make this happen, because we know in pathomechanism, if there is a tear in hyaloid, anterior hyaloid, maybe the aqueous will go posteriorly, and then vitreous will push. Maybe I'm not sure about that. Push the anterior lens to the anterior, maybe like that.
I have a question. Can you check the leak of aqueous humor through the wound of cataract surgery? Corneal incision from the corneal incision. So could you check the leak of aqueous humor from the cataract incision? No?
Yeah, we can check.
You checked
But
it?
I'm not sure she's doing it because here are a case from my patient in her place, peripheral area from Makassar. So I'm not sure if she checked or not, but this condition happened, and maybe she want to know if it's malignant glaucoma, or maybe it's something like suprachoroidal or effusion. Suprachoroidal effusion could happen, or suprachoroidal hemorrhage, pre-suprachoroidal hemorrhage, maybe the cause of this condition. I was thinking about that.
So the IOP was 11 millimeter mercury. It's low, so it's hard to diagnose a malignant glaucoma in this situation.
Yes, we have a very minimal information about that. Then she just wondering that is the case because of the malignant glaucoma or not, because we have not many information about it, so maybe we cannot make sure that this patient have malignant or not. So, and then we also have a question from one of participants. She asking that inophakic eyes that are prone to angle crowded. So what is the tip for performing phacoemulsification or cataract extraction safely? So to prevent intraoperative malignant glaucoma or maybe postoperative malignant glaucoma. And then in this and then the second, what step that we can take during surgery to reduce posterior pressure and avoid aqueous misdirection in a situation that where gonioscopy, OCTA, or UBM are not available. So what is the sign that can help us diagnose malignant glaucoma early? So maybe she live in a peripheral area, so she just have a tonometry and then have a slit lamp. So how she or he predict that this patient have a malignant glaucoma or not just by the equipment that they have in the hospital. So maybe we can hear also the opinion from Dr. Mirella about the questions.
Yeah, thank you, Dr. Henry. So actually, I never have a experience about glaucoma malignant during surgery. So I think it's a little difficult to diagnose glaucoma malignant during surgery. What we can do in my daily practice when I do the operation for the shallow chamber patient, actually I usually try to put just enough amount of viscoelastic, because when we put too much viscoelastic, it tends to be more make the iris will prolapse from the main incision, so it will make us more difficult. Usually I do the trick like that, and if the patient have a high IOP like 21 or 22 before the surgery, usually I give acetazolamide 1 day before the surgery to maintain the IOP during the surgery. That's my daily practice usually. Thank you, Dr. Tenri.
Yeah, Dr. Ari, do you have opinion about that?
Okay, thank you. Thank you, Doc. So for phacoemulsification, maybe for me, just make the anterior chamber keep form, because when we do sudden decompression or a sudden loose IOP, maybe condition, it will trigger the condition of malignant glaucoma. So keep forming the anterior chamber, not too much viscoelastic, but just form the anterior chamber. Try not to make the anterior chamber collapse. That was for me, but and right after surgery, maybe for me, as for filtering surgery, I will put like a drop-in to make to to push the lens to the posteriorly, the zonial to posteriorly, so that the mechanism of malignant glaucoma is not happening here. Thank you, Doc.
Thank you, Dr. Ari. Maybe opinion from Dr. Hiroka about the questions?
I think there is no way to prevent the posterior pressure, to reduce the posterior pressure during the surgery. There's no way. Sorry, so if the posterior pressure is increased, we only wait, just wait 5-10 minutes. Maybe the posterior pressure is decreasing. So there's no way to prevent intraoperative malignant glaucoma. Sorry.
Yeah, thank you, Dr. Hiruka. Because we have many cases like that. Patient come with hard cataract, and then we have many cases for angle closer glaucoma, close angle closer glaucoma in here. So the last questions, because we run out of time, to Dr. Okada. Does that patient need to continue receiving atropine? Dr. Okada, maybe you can see from the chat box.
Yes, yes.
Yes.
Thank you for the questions. I think there are no consensus whether we need to keep atropine after the vitrectomy, but I use atropine to these patients for first 3 days post-op.
Do you mean pre-operation? Before surgery or right after surgery?
Because this patient's preoperative pressure was over 30 millimeter mercury, very high. So
Very high.
I decided to perform my ZHV on the same day. Very emergency surgery.
So no use tropin. You don't use tropin after surgery.
Yes, but if the patient's preoperative pressure was not so high, I tried atropine and just wait and see. And if AC depths become deeper, I don't perform my ZHV.
Any comment maybe from Dr. Hiroka?
Sometimes if we stop the atropine, the malignant glaucoma, it's recurrent malignant glaucoma sometimes. So some patients, it's not hard to stop the atropine, but some patients, we can stop the atropine. It depends on the patient.
There is a question, I think it's the last question to Dr. Okada. In clinical experience, what intraoperative indicators most reliable predict long-term success of EZVD beyond immediate deepening of the anterior chamber?
Thank you for the question. It's a very challenging question. Before deepening of the anterior chamber, I always perform vitrectomy without irrigation for 10 to 20 seconds. But if the time needs more, I think the case is becoming more challenging. But I think there are no indicators during surgery.
Maybe any opinion from Dr. Ella or Dr. Ari?
Yeah, I think for this question, Dr. Tenri, the indicator for long-term success, it's the intraocular pressure control well as we target the IOP. I think that.
Dr. Ari, maybe?
Thank you. For me, maybe regarding to the pathomechanism, we could see if as long as we make a direct communication between anterior chamber to the vitreous cavity, I think it's okay. It will never going to recurrent or something like that because we try to make a direct communication so the vitreous aqueous will not go back, and instead of going back, they will go to the posterior chamber as a routinely. So the IOP, I see a lot of journal also say that they put drop in and for to prevent malignant glaucoma to come again. Maybe that's all.
Any opinion from Dr. Hiroka about these last questions?
Yeah, I think it's hard to indicate the it's hard to understand the interoperative indications to long-term success. But a couple of days after the IZHV, the IOP was good. I think that's one of the indication of the long-term success.
Okay, thank you very much, Dr. Hiroka, Dr. Okada, for the case presentation and also a very excellent cases also from all of the presenter. And I think that question is the last questions. We also have a run out of time, and now it's in Makassar. Now it's about 8 p.m. I don't know in Japan, maybe almost the same, 8 p.m. So so for the discussion and for the presentation, we have to close. Thank you very much to Dr. Hiroka, Dr. Okada, Dr. Milela, and Dr. Ari. This meeting, this Zoom is very useful. Hope this meeting is very useful for all of us, and we really appreciate it for your time. Also for the university, Hiroshima University. Thank you very much. You share the knowledge and your experience also to us, and I'm sure that this meeting is very useful to for our knowledge and also for how we treat our patient in the clinic and also in this hospital. So, and also thank you very much to the audience. Today, this evening, we have about 100 audience. So, we also invite not only in Makassar, but also in other province also. So, thank you very much for this meeting. And then before we close, if you don't mind to take a picture. So I give to the MC, Nurul Isa, please.
So as we reach the end of today's inspiring scientific meeting on glaucoma, I would like to extend our appreciation to all of our distinguished speakers, moderators, and participants who have contributed their valuable time and expertise and also their enthusiasm. Before we officially close, we would like to kindly invite everyone to join for a group photo session on Zoom. Jadi mungkin partisipan boleh menyalakan kameranya untuk sesi foto bersama terlebih dahulu. Please turn on your camera so we could take pictures. Yeah, okay. So on the count of three. 1, 2, 3. Next slide. 1, 2, 3. Okay. Next slide. 1, 2, 3. And last slide. 1, 2, 3.
Thank you.
Thank you. That
Thank you,
concludes
Dok.
our
Dr.
meeting.
Hiroka Sensei. Thank you, Dr. Okara Sensei.
Nice to meet
Hi.
you.
Arigato.
Bye-bye.
Bye. Thank you very much.
Thank you so much.
Terima kasih banget.
Terima kasih, Dok.
Siapa yang kita jadikan korban nantinya?
Masih ada.